Thank you guys for joining us on this Expedition Facial Trauma workshop. My exposure to facial trauma comes from working as a Medivac surgeon and doing maxillofacial surgery in India, where I did my master's. I worked in the mobile surgical services in New Zealand as an oral surgeon. I taught maxillofacial surgery as a VSO in Malawi and did the Medivac rotation here in UK. But I am not a maxillofacial surgeon. I'm just sharing the knowledge I've gained in this field by working as an oral surgeon in an austere environment. So feel free to discuss and take advice from your local maxillofacial surgeon. So I work in Leeds as a general dental practitioner in NHS practice. So this is just sharing my experience in the oral surgical field with you all. So I decided to break this workshop into 3 modules. By the end of the first one, we will discuss lower jaw fractures. The second one, we will discuss upper jaw fractures and maintenance of airway, how you would take the semi-definitive measures to maintain an airway in the field, and how to deal with a dislocated jaw joint. We will essentially be dealing with the atraumatic anterior dislocation of the jaw joint. So where did the concept of this workshop come from? Before we start, we have to mention the caveat of this workshop is that we definitely need a Medivac in this situation. It is only when you cannot get a Medivac or a Medivac is delayed, the situation is urgent, and you developed a good skill set that you will then embark on this journey. So with regards to the lower jaw fractures, we will essentially first discuss examination, diagnosis, and primary stabilization. So where did the concept of this workshop came from? The concept of this workshop came from friends of ours who were doing a rock climb in Kyrgyzstan, and they were faced with a major mandibular fracture, and they could not get a Medivac for up to 10 days. So what would you do when you are faced with this situation? The first thing what you would do would have a quick primary assessment, check the situation out. Secondly, you will radio the base camp and seek for their assistance and help. Now your first objective will be to prevent this patient from fainting. It's a long multi-pitch climb. He or she would not have eaten anything for a long time. So you have to get some food or fluids down the patient's mouth as soon as possible. Your first challenge in this respect is, what if you're faced with something like this, a floating fractured mandible, and the patient is unable to swallow his fluids? What can you do in this situation? What you can do in this situation is grab the tip of his tongue, pull his tongue downwards and forwards, exposing the posterior 1/3 of his tongue. Then take some gel, squirt it in the posterior 1/3 of his tongue, raise his tongue upwards and backwards, and this forms a natural channel which will allow the gel to go into his stomach. Now your next objective would be to transfer his patient from the site of injury to the base camp. And you are not carrying any splints with you. However, the body itself has given you the splint, and the splint is your intact upper jaw. What if you could pull your fractured lower jaw against the intact upper jaw and hold it there? You can do that by tying or using a simple buff or by tying a barrel bandage. And this comes to our first hands-on module, how do we tie a barrel bandage? So if you want to tie a barrel bandage, you take a long tubular piece of cloth. The center part of this tubular piece of cloth goes below the chin. Then you give an upwards and backwards traction. Now surface area here is the key, because you want the barrel bandage to extend all the way from the chin to your angle of your neck, encompassing the maximum area below the lower jaw. When you exert an upwards and a backward traction, you want to tell the patient to take his or her hand and support the barrel bandage below the lower jaw. That way, she supports the barrel bandage as well as she pushes the fractured lower jaw against and holds it against the intact upper jaw. So now you have two tail ends of your long tubular piece of cloth. Take one tail end, and then that one tail end will go all the way across to the top of your head, all the way across, and it goes to the opposite ear. Now it's important again to use the maximum surface area of your head. So you're going to make sure it goes all the way top to the head, to the vertex of your skull, and then crosses over just above the opposite ear. Now when you cross it over this ear, you got to make sure that this knot does not slip. So we are talking of this knot here. We got to make sure that this knot stays just above the ear, because this is the foundation knot of your barrel bandage, and you don't want it to make or let it slip up, down, front or back. You want it to remain just above that ear. So now you again ask the patient to take her hands and support it, one, below the lower jaw. You're supporting the fracture mandible and the barrel bandage. And then take her other hand and support it, the barrel bandage, on the vertex of her skull. So that way we make sure it does not slip around the skull and maintains its position there. So now you got two tail ends. Now take the front tail end, goes all the way just above the eyebrows on the forehead, just above the eyebrows here. And the back tail end goes behind the occiput here. Again, surface area is a key. So you are encompassing the maximum diameter or maximum circumference of your head. And now you take the tail ends and you then cross it over the opposite ear. It crosses here, and then you tie a knot there, and you tie a knot and you tuck these two tail ends on the side. So this is what the barrel bandage should approximately look like. Let us summarize this with a video. So you've taken your barrel bandage, goes below the chin, all the way along the lower border of the mandible, around the top of the head, crosses over the ear, front tail goes above the forehead, back tail goes behind the occiput, you cross it over the opposite ear, tie a reef knot and tuck the two tail ends in. So once you have done that, then the patient reaches your base camp. So then what happens at the base camp? At the base camp, what is the position of the patient? The position of the patient is supine with his or her head slightly elevated. The patient would have swallowed a lot of blood. So patient will be predisposed to vomiting. So you have to keep the patient under closed observation. Now it might be just you and the patient in the tent. So you have to retract the cheek, work in the mouth, get some illumination all at the same time. What you can do is take a torch, tape it to the end of a spoon or a wooden spatula. That way you get illumination and retraction all at the same time. What do you do next? What you do next essentially depends on how soon you can get Medivac. Before anything, you have to make sure that you eliminate any other injuries. You eliminate loss of consciousness, eliminate any underlying injuries, palpate the spine. Face injuries can be fixed in 3 weeks' time, but other like spinal or head injuries require critical and early management. So for the purpose of this sessions, we will be discussing an isolated mandibular fracture where there are no other injuries. So we will be concentrating only on the lower jaw fracture, and we will presume that the patient has escaped this 10 to 14% chance of other injuries in his or her body. So after you eliminated any other injury, you position the patient, you got your thoughts together. What you do next depends on how soon the patient gets a Medivac. If the patient gets a Medivac in 24 to 48 hours, you stay with your barrel bandage. If it is a Medivac longer than 48 hours, you might have to take a wire and tie it across the fracture line. And this is known as a bridle wire. We will discuss that in our next sessions. If you still cannot get a Medivac, or the Medivac is delayed for 72 hours a week, then you might, or it's a rough, bouncy Medivac, you might then have to wire the jaw together, and we will discuss that later also. Now, what else are you likely to see in the tent? In the tent, you're likely to see a progressively increasing facial edema. You tell the patient to try to open the mouth. The patient is either unable to open the mouth, or the mouth deviates to one particular side when he or she tries to open it. When you put your finger on the mandible and try to move the mandible up and down, there will be a sort of a motion of rubbing two sandpapers across each other. When you take your lower finger and palpate the lower border of the mandible, you might find a step deformity. However, what if you have a situation where you cannot see anything, but you have a suspicion that there is or could be a fracture mandible? Is there a particular test that you could possibly do to rule this thing out, or to increase your suspicion levels or decrease your suspicion levels? Yes, and this is known as a wooden spatula test. In this case, what you take is a dried wooden stick, and you take a dried stick and you tell the patient to bite on it with his or her last molar teeth. So all the way at the back teeth, not the front, the back teeth on one particular side. Then you give the end of the stick to the patient and tell the patient to try to twist and break it. If the patient is able to do that, then repeat this test on the opposite side to rule out high possibility of fracture mandible. However, if the patient gets acute pain or is unable to break the stick, then your suspicion levels that there is a fracture mandible will be further increased. So let us summarize this test. So I've taken a wooden spatula, I'm biting it all the way back on the molar teeth, the back teeth. Then the patient grips the other end of the stick and tries to twist and break it. If he or she is unable to do that, then you know that there's a possible fracture mandible. If they can do it, you repeat it on the opposite side to rule out fracture on the opposite side. What else are you likely to see in your tent? You could see a totally collapsed jaw due to the fracture mandible. You could see an anterior open bite. Now this has taken place because of the fracture. The back teeth have gone higher up and the patient bites on the back teeth first, preventing him or her biting with the front teeth, resulting in an anterior open bite. Okay? Or you could have a unilateral open bite. You could get the classical step deformity. You could get a situation where the teeth and the bony fragment, bone holding the teeth is broken, or you could have a situation where the teeth, the bone holding the teeth and the mandible is fractured. You could have a major soft tissue injury without a fractured mandible, or you could have a unilateral cross bite. Now, what do I mean by unilateral cross bite? Essentially, as I said before, if the maxilla is intact, usually the mandible fits into the maxilla. So the teeth of the maxilla or the upper jaw is on the cheek side of the lower jaw. However, because of the fracture, the teeth could have crossed outside. So instead of the teeth of the upper jaw lying on the cheek surface of the lower jaw, because the lower jaw teeth have escaped or crossed outside, the teeth of the lower jaw now lie on the cheek side of the upper jaw. And this is known as a cross bite, as they've crossed outside their confines within the maxilla. You can see a little cross bite there. You can see a big cross bite there. You could see a big whopping unilateral open bite. You could have multiple fractured fragments, or you could have a solitary fractured fragment, or you could have nothing. Now, it all depends upon the muscle pull and the direction of your fracture line. If the muscle pull and the direction of your fracture line is favorable, then there is a possibility that you will see nothing. So you will then have to concentrate on your soft tissue signs. And this could be something like bruising in the floor of your mouth, which is also known as a sublingual hematoma. When you see a bruising in the floor of the mouth, you should automatically get very suspicious, and he has a fracture which is going through here. So therefore, it's important to concentrate on the soft tissue signs or the neurological deficit. So basically, if you tap his lips and his lips do not feel any sensation, that means the mental nerve which is coming out has got bruised or is torn. So there is a high possibility of a fracture mandible. So how does that happen? The big nerve or the inferior alveolar nerve goes here through the mandibular foramen and travels through this bony mandible to the lip, and giving out the mental nerve here which comes out and supplies the lip. So if there was a fracture here, this nerve has got bruised or torn, and hence the mental nerve will not function well, and the patient will get numbness on his lip, and that should make you really suspicious. So why should you temporarily stabilize a jaw fracture? It would definitely increase the patient's comfort. By holding the bony fragments together, it would reduce the bleeding. By preventing the bony fragments moving up and down, it will minimize the further tissue damage. By holding the bony fragments, you will then be holding the tongue forward, and that would keep his airway open. He would also prevent edema of the bony fragments moving against each other, and that would also protect the airway, and it would considerably stabilize the patient before transportation. And therefore, we've looked at a barrel bandage, and now we will look at the simple bridle wire, and then we will look at jaw wiring using the IV loops. So let us look at secondary stabilization with a bridle wire. Now this is what you're going to see in the tent. You will see a mouth open and a lot of blood pouring out. So when a little bit of bleeding in the mouth stimulates the saliva, and you have a lot of saliva forming. So you might think that the patient is bleeding a lot, but actually it could just be a lot of saliva and a certain amount of blood. So first thing to do is to clean everything up. And when you clean everything up, this is what you might find, that there's a fracture line going between her incisor teeth. And now if you strip the soft tissues away, you will notice that is your fracture line. And you'll notice that often it may not be a clear-cut fracture line. It could have shattered into little pieces. Let us turn it around. And as we turn it around and move that away, you will notice, see, the fracture line is not a clear-cut one. There is a solitary fragment here, a crack here, and it's shattered in this respect here. Why is that so important? Is when you try to reduce it or hold it together in an austere environment, you may notice that it does not approximate very well. That is because the fragmented bit of the fracture is interfering in the fracture coming together perfectly well. I would suggest not to worry too much about it. Just get approximate stabilization and reduction, because the finer stabilization and reduction will be done when the patient is medivaced to the healthcare center. Rather, here all you want to do is to hold the bony fragments together to reduce the bleeding, improve the patient's comfort, and help in transportation and protect the airway. Right, so therefore what can you do? You can take a piece of wire, and if this is your fracture line, 2 teeth away from the fracture line, you push your wire from the cheek side to the tongue side. Then you grasp it from the tongue side, 2 teeth away from the fracture line, you push it from the tongue side to the cheek side, and then tie it across on the cheek side. So you noticed I said 2 teeth away. Now why? Why is it 2 teeth, and why not 1 tooth away? Why not 3 or 4 teeth away? That is because if this is your fracture line and you are putting your wire one tooth away from the fracture line, like so. You're pushing it in, going around to the tongue side, and then push it from the tongue to the cheek side and tying it up here. Because of this fracture line here, this tooth has got very poor bone support in this mesial or the anterior area here. These teeth are single rooted teeth. So if you're just going one tooth away here, one tooth away here and tying it here, as you tighten it, because of the poor bone support centrally and because this is a single rooted teeth, these teeth will have a tendency of popping out. So that is why it is 2 teeth away. Why not 3 to 4 teeth away? Because if you do it 3 to 4 teeth away and your wire goes all the way across here, it'll tent across this area and will not give you sufficiently rigid fixation in that area. That is why it is 2 teeth away from the fracture line. Now, as I said previously, if you have to use a wire, but if you don't have a normal wire, you can use any wire you can get your hands on. You can use zip ties. However, they are very fiddly to use. So the first thing to do is we have to stretch this wire. So basically we cut this wire, hold the ends with our artery forceps or a plier, crimp them, stretch them till you feel a give sensation. Theoretically, it is about 10% stretch, but till you feel a give sensation. Then you cut off the crimped ends of the wire. So now you have a nice straight wire to work with. What are the advantages of stretching and why do you have to do it? So basically it gives you a nice straight wire to work with. It also releases the internal stresses, and when you tighten it, after 24 hours, it tends to shrink a little bit from memory, and therefore it will hold your fixation will get even more rigid. So that is the advantage of first stretching a wire before you start your wiring. Now, as I said, oral hygiene takes a back seat on an expedition. So you can see all the debris which is collected here, all this mucky debris at the back of the teeth here. And you can see that this debris occupies a space between the teeth. Okay, because it occupies a space between the teeth, there will be no space for you to push your wire between the teeth. So therefore, the first thing is to make some space to establish a tunnel through which you can pass your wire. So you take any sharp object. This could be a sharp needle. This could be any sharp object which you have. So a syringe needle, and you push it between the teeth. And this allows you to push your wire then between the teeth. At this point, often I'm asked that, will you need local anesthesia for this? You will definitely need a local anesthesia for this. So in this case, ideally, you might have to give a bilateral mandibular nerve block. The internal muscle structure, the tongue, will prevent the tongue from falling back. So there's not that much that you have to worry about that respect. However, it does make the patient quite uncomfortable when you give a bilateral block because the tongue tends to get numb and it's a bit of an odd feeling. So it's a good idea to reassure them. You also have to give a local infiltration. So when you give a local infiltration, if I go back, if you're giving a local infiltration, if this is your fracture line, you will probably give a local infiltration which will numb the local area as well as decrease the bleeding in that area. So you'll give a block here, you will give a block here, and you will give a local infiltration. But when you give a local infiltration, it's a good idea to give it a buccal local infiltration, at least 2 or 3 teeth away from the fracture line here and 2 or 3 teeth away from the fracture line here. The reason is that if you give it too close to the fracture line, because of this fracture line, there's a degloving of the soft tissues. So when you inject here, all the anesthesia will just pour out from the soft tissue laceration here. So therefore, if you go to 3 teeth away and 3 teeth away, that area is still not degloved sufficiently and will hold the local anesthesia, because the local anesthesia is held in that area and has a vasoconstrictor in it that will decrease the bleeding, improve your vision, and make the patient more comfortable. So you stretch the wire, you made a space to push your wire between the teeth. You take your wire and you follow this black line, black arrow. So basically you're pushing it from the cheek side to the tongue side. If this is your fracture line, it is 2 teeth away from the fracture line, cheek side to tongue side. Then you grasp it on the tongue side, and then 2 teeth away from the fracture line, you push it from the tongue side to the cheek side. Next, what we got to do is to take our index finger and we place the index finger on the tongue surface behind. What it does is that it holds the wire in place and it adapts it to the tongue surface of the teeth. Make sure it does not move away, and make sure that you don't have any dead space between the wire and the tooth. Then you grasp the front 2 ends, you cross them and you grasp them with your artery forceps. Okay, you try to grasp it relatively close to these teeth. You cross them, grasp them with the artery forceps or a plier, and then you turn it in a clockwise direction, and you turn it 3 to 4 times in a clockwise direction. So what you have is, you would have got now a relatively loosish wire with 3 to 4 ties, and these are the 2 tail ends of the wire. Now you trim this wire down. Essentially you're trimming the tail ends of it down. Why do you do that? Because it's still not tight. You do it now because it's much more easy to work with, because you already started the tying process and you get a much tighter tie when you do that. So you trim the tail ends of this wire out, you trim the tail ends up, okay, and then you do the final tightening. So when you do the final tightening, see, it's easier to work with. You twist the wire so that the wire gets twisted towards the teeth and gums. So you twist it. This knot sign means twist the wire, not tie the wire. You twist the wire and the ends go towards the teeth and the gums. Okay. Now what if you want to take this wire out? This could be for many reasons. It could break when you've been tying the wire and therefore you need to take the wire out, or for any other reasons. So we turn it in the anti-clockwise direction, we loosen it, we cut one end of the wire, we grasp it with the artery forceps, and then we pull the whole thing out towards the cheek. So we are just pulling this whole thing out towards the cheek. Yeah. Okay. So that is how we take the wire out. So let us summarize it with a video. Finger, index finger on the tongue side, cross the wire with the artery forceps, turning it clockwise 3 to 4 times. See how well it's adapted to the tongue side with my index finger. Turning it 3 to 4 times and the wire is still loose. And now I'm going to trim the wire. So I'm going to cut the ends of the wire. Now this is the wrong way to cut it, is when you grasp it with the artery forceps and you just cut the end of the wire off. That's the wrong way. The correct way is to grasp the end with the artery forceps and then cut it. That way you will not, the cut wire will not flick into your eye, or you will not lose it in the patient's mouth. That is a danger with the first technique. So that is the wrong technique. The second one is the right one. So now you do the final tightening. As you do the final tightening, it is twisted so that the ends go clockwise towards the teeth and gums. So the sharp end is not sticking out into the lips, irritating the patient. Okay. Now that is how to do a bridle wire. However, we have noticed we've done a bridle wire. So we done a barrel bandage when the patient got injured. We brought them to our base camp. We realized that Medivac is not coming for the next 72 hours to 4-5 days. We decided we're going to put a bridle wire on. The weather turns and they say that the Medivac is going to be delayed by another 7 to 10 days, or it's going to be a rough Medivac at the back of a pickup truck. And you decided that in addition to your bridle wire, you want to wire the jaw together to further stabilize the lower jaw and to prevent it bouncing up and down. So how do we do jaw wiring? Whereby we are wiring the bottom jaw to the top jaw, approximately just holding it in place to give it added support. So for that, we have to make eyelets, which are called IV eyelets. Okay, that is a write-up about it. What is an eyelet? An eyelet is essentially a round piece of wire with a short twisted section and two long tails. Okay, so let us show it to you in actual life. So round wire, short twisted wire, and two long tails. So that is what an eyelet looks like. So how many of these would we have to make? You will have to make 8 of these. Why 8 of these? So we need 4 for the upper jaw and 4 for the lower jaw. So the 4 in the upper jaw, where are they placed? So the first one is placed against the upper molar teeth. The second one is placed against upper right premolar teeth. The third one, upper left molar teeth. And the fourth one, upper left premolar teeth and the upper left molar teeth. Similarly, you need 4 for the lower jaw. In the lower jaw, you place one on the lower left molar teeth, lower left premolar teeth, lower right premolar teeth, and lower right molar teeth. So 4 are attached to the upper jaw, 4 are attached to the lower jaw. Then, so we put 4 in the upper, 4 in the lower. So now we push the mandible against the maxilla and we have to join the bottom loop to the top loop. And we join the bottom loop to the top loop by what is known as a bridging wire. Now the bridging wire is such that it goes through the bottom loop, then goes through the top loop, and then you tie it up, joining the top to the bottom loop. Okay, so it's essentially a straight wire which joins the top loops to the bottom loops. How many of these do you need? You need 4 of them. So the first one will join the eyelets, upper and lower, on the right side, upper and lower molar. Second one, upper and lower premolar. Third one, upper and lower left side premolar. And the fourth one, upper and lower left side molar teeth. Now, how do we attach these eyelets to the mouth? We attach it. You see these 2 tail ends? We push both the tail ends from outside inside. Then we grasp one tail end, which is then pushed from inside back outside. Second tail end is pushed inside back outside, and this second tail end goes through the loop and is then tied to the front tail end. So the second tail end goes through the loop and is tied to the front tail end. That is how it's done. So this is the back wire which is going through the loop and is then tied to the front wire. Okay. Now we're just going to go through all this. First of all, how do we actually make this eyelet? So we take a straight wire and we again stretch it. When we stretch it till you feel a give sensation, then we take a nail and we place the nail in the center. Sorry, have a sip of water. We take a nail and we place it in the center of this straight wire. Okay. Once we place the nail in the center of the straight wire, we then cross these wires as close to the nail as possible. So we cross this wire as close to the nail as possible, about that close. So we do not cross this wire about as far away here or here. We cross it close to the nail here. Okay. I'll explain why. Because you crossed it close to the nail here, and now we turn the wire 3 to 4 times in a clockwise direction. And this is what we achieve: a round loop, a short, tight, twisted section, and 2 long tails. We got this short, tight, twisted sections by crossing our artery forceps close to the nail. If we had crossed the artery forceps far away from the nail, we would have got a long, loose, twisted bit or a very, very big, loose loop. Okay? And that is important, and I'll tell you why. So, how do we stick this or attach this to the teeth? You see this red arrow. We push both the wires from cheek side to tongue side, we push it through both of them between these two teeth following the red arrow. Then we take our back wire. Our back wire goes from tongue side to cheek side, one tooth away from where we pushed it. The front wire goes from tongue side to cheek side, one tooth in front of where we pushed it, like so. Now, so basically we got a back wire coming back out, front wire coming back out, and that's got all the way around this tooth and all the way around this tooth. Now, it is important that your short twisty bit just fits the space between the teeth. So it should be long enough just to go from here to here between the teeth. And that is why it should have a short twisty bit, which we achieved here. Now, if you had grasped your artery fossa far away and twisted it, you would have got a long twisty bit. In this case, because the long twisty bit would have stretched from here between the teeth and could be sticking on all the way into the cheek about here, your loop would have been here, and that would have been too far out onto the cheek side and would have affected the rigidity of your fixation. So you need a short twisty bit so that the loop lies very close to these teeth and not far away. Okay, once you've done that, then what we do is we take a back wire and pass it through this loop. You see that? It's going through the loop, and tie it with the front wire. Again, we tie it in a clockwise direction. Tie is a wrong terminology. It's twisted with the front wire in a clockwise direction. Okay? So, sorry. So basically, we run this as a hands-on workshop, and through the multiple times we've run it as a hands-on workshop, there's certain mistakes which we noticed. And let us summarize these mistakes, so make sure that you don't do the same mistakes. What are those mistakes? If this black is your loop, the red and blue is your short twisty bit. This is the back wire going from inside back outside. This is the front wire in blue going from inside back outside. This is the front teeth, that's a back teeth, that's a tongue, and that's a cheek. Okay? So do not take your front wire, pass it through the loop going backwards. Don't do that. Do not take the front wire, which is the blue one, going through the loop from front to back, and the back wire shown in red going through the loop from back to front, crossing within the loop. Don't make them cross within the loop. Then, do not take your back wire, go over the loop and twist it with your front wire. So don't go over the loop. What you have to do is take your back wire, let it go through the loop and twist it with your front wire. So back wire goes through the loop and is then twisted with your front wire. So this is the way to do it. Right? So now that you've taken your back wire and it's gone through the loop and is twisted to the front wire, so basically we again turn it 3 to 4 times. It is still not tight, and then we, just as your bridle wire, we twist the ends of the wire 3 to 4 times. It's still loose, and we trim this wire down just as we did in the bridle wire. So it is still loose, and we just trim the twisted bits down, and then we do the final tightening, and with the twisted end, which is here, we tuck it towards the teeth and gums so it does not poke into the cheeks of the patient. Now, for some reason, which mainly would be that you are fixing your IV loop and your IV loop has broken or snapped when you're twisting it, because that could be the only reason why you have to take it out and replace it. Because normally, once you put the IV loop in, we do not take it out. We send them to the primary healthcare center or the secondary hospital, and they will deal with that. So there is only a few occasions, and this could be possibly the only occasion, that you put the IV loop and now you got to take it out because it's snapped or broken. How do we take it out? So basically, it's good to know how to take it out. Is that you see this twisted bit, we essentially cut the entire twisted bit out. So we cut the back wire which has passed through the loop and is twisted to the front wire. We cut that out, we cut the front wire out, and the back wire which passed through the loop, we pull that wire out. So therefore now there is nothing going through the loop. So this was the twisted end is cut off, as you can see here. Then I pulled the back wire out through the loop, so it's no longer going through the loop, and the loop is isolated by itself. And that is what I grasp with my artery forceps and pull out. So that is how you take an IV loop out. Okay. So we put the IV loop in the bottom. We put 4 of them, essentially 4 in the top, 4 in the bottom. Okay. But we are showing it only with 1. So this is the bottom IV loop, this is the top IV loop, and we have to join the bottom one with the top one using a bridging wire. So we take a straight wire, and just as this guy is going from front to back through the loop, similarly we push a wire through the loop from front to back, and then we turn it around, and then just as this guy is going from back to front through the loop, we push the wire from back to front through the loop. So now the wire has gone from here, gone through this loop, turned around, and then gone back to front through the top loop. Okay. This is another technique to tighten the wire. In this technique, what we do is we grab one artery forceps at one end, another artery forceps at the other end. We then cross them. This is a really good technique if you're working with a dodgy piece of wire. And the reason why it is good is in this technique, we are symmetrically twisting the wire one over the other. Whereas in the other technique, one rolled over the other, whereas here we are symmetrically twisting the wire one over the other. So there's equal stress on both the wires and less chance of them breaking when you are twisting them. So basically we cross them at 90 degrees and then clockwise we twist them one over the other. We just start this whole twisting process off. Once we've done 3 to 4 to 5 turns, we then, just as our previous wiring techniques, we trim the ends of this wire off. We trim it off, and you can see it's still loose. We trim it off, and then we are trimming the wire off. It's still loose, it's not tightened, and then we are doing the final tightening. And then we do the final tightening, tucking the ends towards the teeth and gums so it does not poke into the cheek mucosa. Okay, so let us summarize this. So we are taking a straight piece of wire, and in the center part we are putting, this is a center part, we are putting a nail in. The nail goes in, we are holding an artery forceps close to the nail, we are turning it 3 to 4 times in a clockwise direction, 3 to 4 times, and then magically we will get our IV loop, a short twisty bit and 2 long tails, right? So now we are pushing it from the cheek side to the inside of the mouth, from outside inside. Then the back wire, the front wire, will go from inside back outside, and the back wire will go from inside back outside and will come out here, 1 tooth away from where we push this one in. So it's going from inside back outside and it comes out here. Now the back wire will go through this loop and will be twisted to the front wire. So we take the back wire, it goes through the loop, and then we twist it to the front wire. We are twisting it to the front wire like so, and we twist it. Once we twisted it considerably, again it's loose, so now we'll be trimming it down, and then we will be doing the final tightening. So we trim it down, and then we do the final tightening of this wire, and we tuck it in towards the teeth and gums so it's not sticking out into your lip. If you want to cut it out or take it out, we loosen it, and then you will notice that I'm cutting the back wire which has gone through the loop and is twisted to the front wire. The back wire is cut. Then the front wire will be cut here, so I'm removing the entire twisted bit. Front wire is cut. Now we will pull the back wire out through this loop. You take it out, push it out through the loop to take it totally out. So there's nothing now going through the loop. Grab the loop and pull the loop towards the cheek side. So we're taking it out. The bridging wire is going through the bottom loop from front to back. then we turn it around, then it going through the top loop from back to front, like so, and then so it's gone through the bottom, through the top. We grasp the other end with an artery forceps. So both ends are grasped with the artery forceps. Give it a bit of traction, tighten the mandible firmly against the maxilla, and now we cross it at 90 degrees, and then we twist it 90 degrees, and we twist it 3 to 4 to 5 times. Just you have to start the twisting process off. There's no need to make it nice and tight or neat. You just have to start it off. You can see it's quite a fiddly process. So it might be like a loose and uneven like this one. And now we trim it down, and then we do the final tightening. So it's much easier to do it then. So we grasp the end, and then we twist it not anti-clockwise, but we twist it clockwise. There we go. We twist it clockwise, and we twist it till it's nice and tight. Then we trim this end off again till we do the final tightening. And when we do the final tightening, we twist the ends towards the teeth and gums. So we don't want this sticking into the cheek. We want them turned in towards the teeth and the gums. Okay? So we turn it in towards the teeth and the gums. Brilliant. So it's got to be done like that. Yeah? So now patient has difficulty breathing in the tent, and you think, oh, it's much better to quickly open the patient's mouth to check whether everything is okay inside. If you want to urgently open the mouth, we do not touch the IV loops. So the IV loops stay where they are. What we are touching is, or cutting, is this bridging wire. So we do not touch the IV loops ever. Till the patient goes into the secondary healthcare facility, they will deal with that. So all we got to do is to make a small nick in the bridging wire, like here, and then just take that bridging wire out. That way it quickly allows you to open the patient's mouth. You can explore what you want, and then wire it back again, because the IV loops will already be attached, 4 with the bottom jaw and 4 with the top jaw. So basically, what did we learn? We reduced the bite, restored the bite, and stabilized the bite. We remember we always have to pre-stretch the wire before any wiring. We always go in a clockwise direction. Why? Is because if you do in a clockwise direction and the patient goes to the secondary healthcare facility and the MaxFac surgeon wants to tighten the wire, he will know he has to do it in a clockwise direction. If you have tightened the wire in the anti-clockwise direction and he thinks he is doing the tightening of the wire by going in the clockwise direction, he will actually be loosening the wire. So internationally, we always do the tightening in a clockwise direction. We always lightly tighten all the wire first, and then we do the final tightening. We make sure that the tails of the wire are not protruding into the cheek and the tongue, because it might cause certain degree of lacerations there. So we make sure the tip is always turned in towards the teeth and the gums. We do not want to cause added aggravation of the patient by having a wire sticking into his or her cheek and lips. What is the post-operative care? Because unlike a hospital, you will not be able to transfer this patient to a maxillofacial surgeon. You will have to deal with the patient yourself. So therefore, I divided this how to look after the patient in that the patient gets Medivac in 72 hours, or the patient is stuck to you for a longer than 72 hours. So in the first 72 hours, what is the position of the patient? The position of the patient is supine with his or her head slightly elevated. You will close all the lacerations within 12 hours of injury. That is, or try to close all the lacerations within 12 hours of injury. Oral health care in the first 24 hours, do nothing. You do not have to do any rinsing or anything. Just let the patient be. After the 24 hours, you can gently irrigate the mouth. You irrigate the mouth with warm salt water. Temperature is the temperature of tea. How much salt? Half a teaspoon of salt in a cup full of warm water, which is, as I said, the temperature of tea. You have to feed this patient. So basically what we do is to use a disto-buccal gutter. That is a space between the last molar teeth and the anterior ascending part of the ramus of the mandible. So this is this triangular space which lies behind the last molar teeth all the way to the ascending part of the ramus of the mandible. So that is the section, this triangular bit is a section we will use to drop fluids into the patient's mouth. Initially will be transparent fluids, and gradually you'll go on to thicker fluids. Initially you will drop it using a wide bore syringe, then a small teaspoon, or a combination of both. You can do retraction by bending a spoon and using a spoon to retract the cheek and another small spoon to drop the fluids down in from this distal buccal gutter. Medications, you will need antibiotics and anti-inflammatories. If you have access to PR diclofenac, that would be very useful for these patients. You have to be cautious about some things. Tell the patient not to blow their nose. Why? There could be a possibility for this patient as a part of the injury to have cracked the upper jaw. If there's a thin crack through the upper jaw and the patient blows the nose, the air will be forced through this crack into the soft tissue space, giving a surgical emphysema in that area. So we advise the patient not to blow their nose. Patient would have swallowed a lot of blood and therefore will be predisposed to vomiting. If he or she does feel like vomiting and the jaw is wired closed, tell them to vomit through the wires itself rather than opening it up and then gently irrigate around. Patient will require a lot of reassurance, a lot of support in this respect, which should come from you. Also, you might want to settle the stomach by any means possible. What if the patient stays to you longer than 72 hours? If you can encourage mobility, that would be very useful in the final Medivac of the patient, if you can. The patient would require oral health maintenance. So after every single meal, retract the cheek with a bent spoon, irrigate and wash after every meal to maintain good oral hygiene. Nutrition is 6 to 8 small meals a day, and gradually thickening in consistency from its transparent to more opaque and more thick. You can think of a high protein and high calorie diet, any sort of a high protein and high calorie diet. Double strength milk, which is milk powder mixed with milk, can be used. What is the caution? The caution is strongly recommended that you keep a wire cutter next to the patient's bedside at all times in case it is necessary. Due to the diet, patient may be predisposed to constipation and diarrhea because he's on a high carb and high protein diet. So you have to be just aware of that bit. So in the next session, we will deal with upper jaw injuries, definitive but mainly semi-definitive airway strategies to maintain the patient. If you come across such a situation, you cannot get a Medivac and it's an urgent situation, and how do we manage it? Cheers. Thank you so much.